In this module, I am going to discuss about lower respiratory tract infection. There are two important group of disorders I am going to discuss. One is acute bronchiolitis and other one is pneumonia. First is about acute bronchiolitis. Acute bronchiolitis is one of the common infections. It is a seasonal infection which occurs usually in the winter seasons or in the spring. And this is usually a virus-associated infection, and the most common etiology is RSV. RSV is respiratory syncytial virus, which is the most common cause of acute bronchiolitis. And usually young children are affected by this particular condition. The age group is usually less than 2 years. The common age group which is affected frequently is 1 to 6 months. But remember, any age under the age of 2 years can be affected. Now, let us move on to the clinical description of acute bronchiolitis. This infection usually starts as an upper respiratory infection. To begin with, it's an upper respiratory infection. Around a week later, it would present to lower respiratory problem. And what is the site which is going to be affected? It is bronchioles which are going to be affected, and because of which the child gets fever as a part of infection, along with that breathing difficulty. And when you auscultate these children, at the time of clinical presentation, they will have bilateral wheezing. You can easily remember that the air, as it passes through the narrowed bronchioles, due to this inflammation or infection, it creates the wheezing sound. So what happens? There is a passing of air through the narrowed bronchus, causing the wheezing sound to be produced in these children. Okay. Now, this is the usual clinical presentation. If you take the X-ray of these children, what is the finding you are going to get? A very, very classical finding is bilateral hyperinflation. Let us look at the reason for hyperinflation in the X-ray. This is the trachea, I am writing T, and this is the bronchi. After that comes the bronchioles, like this. In this condition, the bronchioles are undergoing inflammation. I'll take these two bronchioles which are inflamed, and because of inflammation, there is some narrowing of the bronchioles, like this. So what is going to happen? During inspiration, the air will pass through all those bronchioles because they are not fully obstructed, right? So air will be able to still pass through that bronchioles. But during expiration, what is going to happen? We all know that the air columns tend to become smaller during expiration. Okay, so what happened? What was previously a partial obstruction during expiration almost becomes like a complete obstruction. So you can understand that in that affected areas, these areas, the air will not be able to come out easily. This results in trapping of the air inside the lungs itself. And this air trapping is the reason for expanded lung fields, or what you call it as hyperinflated lung fields. You can see that the same problem is also going to occur on the other side of the lung. So this condition is going to be characterized by bilateral hyperinflation. This explains the characteristic bilateral hyperinflation in acute bronchiolitis. You can notice this X-ray showing bilaterally expanded lung fields, or what is called bilateral hyperinflation. And one more finding can also be noted in the X-ray of these patients with acute bronchiolitis. That is, surrounding the hilar region, this area, there is a lot of white markings. It is nothing but bronchioles undergoing inflammation in that area, causing increased markings in those areas. This is what is called as perihilar fullness, or also called as perihilar cuffing. One more important finding noted in X-ray of acute bronchiolitis. I have told the X-ray feature is hyperinflation, And because of this hyperinflation, clinically also, the child can have some findings. For example, the lung is expanded too much. So what will happen? The AP diameter of the chest is increased. Anteroposterior diameter becomes increased due to this hyperinflation. Second thing, if you start percussing over the lung fields, you will have hyperresonance. There is hyperresonance of percussion. Hyperresonance on percussion. Okay, these two are clinical findings noted due to bilateral hyperinflation. So please remember about the typical presentation. Initially starts as upper respiratory infection, later progresses to lower respiratory infection associated with wheezing as well as hyperinflation. This is the classical clinical presentation of acute bronchiolitis. Please remember, most of the times a combination of the clinical features and X-ray is sufficient to make a diagnosis of acute bronchiolitis. However, for exam purposes, you can remember that if you want to look for that virus association in the respiratory tract, you can take the nasopharyngeal swab or the aspirate, and you can send it over for PCR testing. But generally remember, in a usual clinical setting, we don't do this PCR testing for nasopharyngeal aspirate. This is purely for academic purposes you have to know about. Okay, right. Now coming to the treatment or management of acute bronchiolitis. Remember, it is a viral infection. So usually it is a self-limiting condition. So what is required is only supportive management. Okay. Supportive management includes moist oxygen inhalation. This is required to keep SpO2 to more than 92%. And second thing is lot of fluids. Oral fluids are sufficient, but if the child is not able to take oral fluid due to that breathing difficulty, you can give IV fluids as well. So two main things in the supportive management are oxygen and fluids alone. Okay, right. Now, there are certain group of babies where you may need to give antiviral agents. Okay. These group of babies include what is called as at-risk babies. So what are these group of babies coming under the at-risk category? It is children having chronic lung disease, children with congenital heart defects, and children with immunodeficiency. In these group of babies, it is recommended to give antiviral. And what is that antiviral of choice in RSV infection? It is ribavirin. You give ribavirin as an inhalation because this is supposed to decrease the duration as well as severity of illness in these group of children. So that is why only for these children you have to give ribavirin inhalation during treatment. For a normal child, no requirement for ribavirin. That should be remembered. And also for these at-risk babies, before the start of the season, that is the winter season, what you can give is, you can give something like a prophylaxis. Okay, and the agent which is advised for prophylaxis is palivizumab, which, as you can infer from the name, it's a monoclonal antibody. It's a monoclonal antibody directed against the F protein of RSV. Okay, again, this prophylaxis is also for at-risk children. So at-risk children only require specific antiviral treatment as well as require monoclonal antibodies before the start of the winter season. Okay, right. But in general, bronchiolitis is not at all a severe infection. It usually subsides just like any other viral infection within 3 to 7 days. Okay, and supportive treatment is all that is required in management of these children. An additional point to be remembered is 25% or 1/4 of patients with bronchiolitis, they go on to develop asthma in the later life. That is also an association with bronchiolitis that one should be aware of. So that completes the discussion of acute bronchiolitis, which is an example of lower respiratory infection. The next lower respiratory infection is pneumonia. And it's a well-known fact that pneumonia is one of the important causes of under 5 mortality. That means death in children under the age of 5 years. Pneumonia is one of the very, very important causes. Pneumonia can be defined as a pathological consolidation of alveoli or it could be an inflammation of the interstitial tissue, okay, which is surrounding the alveoli, or it could be both. Okay, that is what is a pathological definition of pneumonia. Now let us look at what are the common organisms or etiology of pneumonia. Generally remember, pneumonia is commonly caused by a bacteria when compared to virus. Okay, and if there is a question, which is the overall most common bacteria causing pneumonia in childhood, it is always Streptococcus pneumoniae. Streptococcus pneumoniae. And if the question is slightly modified, the most common cause of pneumonia in neonates, then your answer is slightly different. What we have discussed in neonatal sepsis, the same group of organism only. What is that? It is a gram-negative bacteria like Klebsiella and E. coli. And followed by that, you have Staphylococcus aureus as a common cause. If there is a question, what is the most common virus causing pneumonia in children, then it is RSV. Yes, the same virus associated with acute bronchiolitis is also the most common viral cause of pneumonia in children. Suppose the question is slightly modified. In children with HIV, what is the commonest cause? Then your answer is going to be different. What is that? It is Pneumocystis jirovecii, or what is called as Pneumocystis carinii. Right? Okay. Now, if the question is asked about most common cause of pneumonia in adolescent or older children meaning like after 5 years. Remember, the usual age group of pneumonia we were discussing is under the age of 5 years. Now, this is more than the age of 5 years or even older children like adolescents. So, I will put this as a atypical age group. In fact, the organism causing that pneumonia is also an atypical organism. And what is that? It is Mycoplasma pneumoniae. Okay, so this table is an important table which tells you about the etiology of pneumonia at different settings. Okay, so please make sure that you know this because a lot of MCQs have been asked from this table. As I have said before, pneumonia is one of the important conditions causing under 5 mortality, making it an important public health problem. So that is why there are important community guidelines for management of pneumonia. These are actually taken from revised WHO guidelines, and what we call in the Indian setting, we call them as IMNCA guidelines. According to this, any child with the symptoms suggestive of pneumonia or conditions related to respiratory tract, we will divide them into 3 categories. One is no pneumonia. Second is just pneumonia. The third category is severe pneumonia, or also called as very severe disease. Let us see in detail about the features of each of this category and management of them. The first category is no pneumonia, which is characterized by only fever, cough or cold. There is no other associated features. It's called no pneumonia. No pneumonia is advised home management. You have to give oral paracetamol for management of fever. That is all that is required for this management. And in some of the children with cough, sometimes wheezing is also noted. If wheezing is noted, then you can give salbutamol for 5 days. That is what is recommended for no pneumonia management. The next category is called as pneumonia, which is characterized by fever, cough or cold, but in addition you will have either fast breathing and or chest indrawing. At this point, you should know what is the criteria for fast breathing. It is defined according to the age of the child. If the child is less than 2 months, then a breathing rate of more than 60 per minute is considered as fast breathing. If the child is after 2 months but less than 12 months, that is 2 to 12 months, more than 50 per minute is considered as fast breathing. If the child is after 12 months of age, then more than 40 per minute is considered as fast breathing. So while telling about the criteria of fast breathing, it is very important that you know or interpret according to the age of the child. Okay, so fast breathing and or chest indrawing will be considered as pneumonia. The most important thing to be noted here is SpO2 should be normal, or in other words, there should be no hypoxia. Then only you can call it as pneumonia. For pneumonia, again, it is home management which is advised. Same like before, you will give oral paracetamol along with salbutamol if there is wheezing. But in addition, you always have to start a oral antibiotic. And the oral antibiotic which we give is oral amoxicillin for a period of 5 days. Now at this point, it is very important that you tell the mother to follow up after 5 days, and you also tell about some danger signs which I am going to tell you next. And if there are any danger signs noted, they have to immediately report again. The next category is severe pneumonia, or also called as very severe disease. In this condition, any one of the following should be present, which includes hypoxia. What is the definition of hypoxia? SpO2 less than 90% in the room air. It is called as hypoxia. Or stridor in a calm child. Or any danger sign is present, then also it is considered as a feature of severe pneumonia. What are the danger signs one should be aware of? It is not feeding or not drinking. Child is very lethargic. Child is having cyanosis or bluish discoloration all over the body, or a child having convulsion. If any one of this feature is present, it is called as a danger sign, and immediately that categorization will be severe pneumonia. Okay, so presence of stridor in a calm child or hypoxia or any danger sign, you will categorize it as severe pneumonia. What is the importance? The severe pneumonia, you have to give the first dose of antibiotic immediately. It is combination of ampicillin and gentamicin. You have to give the first dose of antibiotic, and then you have to immediately refer the child to hospital. So think like this: a health worker is in the community seeing this child, or a doctor at a rural level of healthcare is seeing this child. They won't keep the child at that setting or the community setting. They will immediately refer the child to a higher hospital like a tertiary care hospital. This is the importance of classifying respiratory infections into no pneumonia, pneumonia, or severe pneumonia. You should also know about the color coding for each of these classification. No pneumonia is given a color code of green, yellow for pneumonia, and very important, it is pink color for severe pneumonia. Why this is important? Because many of us think severe means we will categorize as red color. No, there is no red color in IMNCA classification. It is only pink color for a severe disease. Okay, that also should be remembered while reading about the community management guidelines for pneumonia in children. Now let us look at X-ray patterns of different pneumonias. First is the pattern caused by the commonest organism. And what is that? Streptococcus pneumoniae. The pattern which is caused by this organism looks like this X-ray picture. Can you see in this X-ray that the right lobe of the lung, that is the right lower lobe of the lung, is completely opacified? This is what you call it as lobar consolidation, and that is the characteristic X-ray picture caused by Streptococcus pneumoniae infection. So lobar consolidation, always remember with Streptococcus pneumoniae. Another characteristic feature of Streptococcus pneumoniae is that it is associated with a typical sputum called as rusty sputum. This is a characteristic description. But please note that young children, they don't tend to bring out the sputum, they swallow the sputum instead. So that is why, even though rusty sputum is a characteristic finding, you don't always observe them in children, because the children usually swallow the sputum instead of bringing it outside. Okay, and if you detect Streptococcus pneumoniae, what do you think should be the treatment? The treatment should be administration of penicillin G, okay, at the dose of 50,000 international units per kg per day. It is usually given intravenously. Okay, that is the usual treatment for a Streptococcus pneumoniae infection. The other common antibiotics which can be useful in the management are co-amoxiclav, that is amoxicillin and clavulanic acid, and next one is third generation cephalosporin. Please remember that in many of the clinical settings nowadays, because of increasing resistance reported by Streptococcus to penicillin, the common antibiotic which we are using itself is third generation cephalosporin nowadays. The typical examples would include ceftriaxone or cefotaxime. Okay, so these are some of the important points for Streptococcus pneumoniae. Next, we are going to look at another organism, Staphylococcus aureus. What is the pattern of pneumonia which is caused by Staphylococcus aureus? Let's look at the picture next. In this X-ray, I want you to remember certain characteristic features. One, you can see that here is an area of consolidation, but it is not involving one full lobe of the lung. Instead, it is something like a patch it is occurring. That is a characteristic feature in X-ray of staphylococcal pneumonia. What is that? It is called as patchy consolidation. Okay. Previously, for Streptococci pneumoniae, I said lobar consolidation. Here I am using the word patchy consolidation. Usually, it is a bilateral patchy consolidation. The second is another characteristic feature which I want you to appreciate very clearly is this air-filled spaces inside the lungs. What are those air-filled spaces inside the lungs? They are called as pneumatoceles. Pneumatoceles. Pneumatoceles association is considered as a very characteristic feature of Staphylococci pneumoniae, and it is also one of the important features which should be followed up very seriously, because sometimes pneumatocele can rupture And what can happen? The air can enter into the surrounding pleural cavity, causing what problem? Pneumothorax. And this we all know is a very dangerous condition. So that is why Staphylococci aureus pneumonia is considered to be one of the dangerous types of pneumonia which can occur in children. So as you have seen in the picture, bilateral patchy consolidation and nematocele are characteristic X-ray findings in Staphylococci aureus pneumonia. There are some risk factors which can predispose to the development of Staph aureus associated pneumonia. What are they? They include children with malnutrition, especially children with severe malnutrition, children with diabetes, and this Staphylococci pneumonia can also occur as a complication to some viral infection. It could occur as a complication of influenza or measles virus infection. These are some of the risk factors for development of Staph aureus associated pneumonia. And as I have told before, this is a severe type of pneumonia because it is associated with complications. One of the complications I have already explained with the X-ray is rupture of nematocele, which can result in pneumothorax. And the second important complication is the pus can also discharge into the pleural cavity, causing pus in the pleural space, what we call it as empyema. So because of these two complications, again I am emphasizing the fact that Staph aureus associated pneumonia is a severe type of pneumonia in children. What is the treatment for this condition? Usually we'll start with a penicillin G or co-amoxiclav. If the child is showing no response to penicillin or co-amoxiclav, then you can start with the third generation cephalosporin, or if you are suspecting the possibility of MRSA, then you have to add either vancomycin or linezolid. These are the usual treatment options for Staphylococci associated pneumonia in children. Here again, in this X-ray, what are you seeing? The very classical air-filled spaces like this, which is nothing but the nematocele. Okay, as I have said, nematocele is characteristically associated with Staph aureus associated pneumonia. That is a number one condition. Number two condition is Klebsiella associated pneumonia or E. coli associated pneumonia. Even though they are not very common causes in children, just make a note of it. And third important condition where you can get nematocele is hydrocarbon poisoning. These are three important conditions which are associated with nematocele, which can very well be asked as a radiology question in your exam. So you should make a note of it. The next is a pattern of pneumonia caused by Mycoplasma pneumoniae or RSV. As I have said before, Mycoplasma pneumonia is also called as atypical pneumonia. And even the pattern of pneumonia will also be slightly different from the typical pattern. Let us see with the X-ray. Can you see in this X-ray, we don't see like a patch or complete lobe getting consolidated. Instead, what you can see is multiple white dots on both the lung fields. Can you notice that? So this is a pattern which is not looking like a typical consolidation pattern. That is why it is called as interstitial pattern, or it is also called as bronchopneumonia. And this is the characteristic pattern of pneumonia associated with Mycoplasma pneumoniae or respiratory syncytial virus or virus associated pneumonia. Now I would like to add some important points about Mycoplasma pneumoniae. As I said before, it usually affects the older children who are more than the age of 5 years. Number 2, these children, they appear relatively well in spite of pneumonia. In fact, if you take the X-ray, you will see a lot of that interstitial pattern on the X-ray. But when you look at the child and their symptoms, it is very, very minimal. So that is why this type of pneumonia is also called as walking pneumonia, to describe that the child is very, very well as well as walking in spite of having pneumonia. That is why it's called walking pneumonia. Okay. And if you detect Mycoplasma pneumonia infection, the treatment is usually going to be by macrolides. The typical example of a macrolide antibiotic is azithromycin. So these are the important points about Mycoplasma pneumonia associated pneumonia, and I have told you about certain X-ray pattern and certain characteristic features along with treatment of different organisms causing pneumonia in children. Now let us look at two important terms called recurrent pneumonia and persistent pneumonia. First, the definitions are important. Recurrent pneumonia is defined as more than or equal to 2 episodes of pneumonia in 1 year, or more than or equal to 3 episodes in a lifetime. This is what is called recurrent pneumonia. And what is persistent pneumonia? It is defined by non-resolving pneumonia characterized by persistent radiological findings. Persistent radiological findings for more than 1 month. You call it as persistent pneumonia. Okay, right. So why should you know about these terms is because these are not normal or usual conditions of pneumonia. It is actually an underlying condition which makes the child to develop recurrent or persistent pneumonia, and if you don't correct the underlying problem, again and again the child is going to present with further episodes of pneumonia. So that is why while evaluating a child with recurrent or persistent pneumonia, you should know about risk factors so that you can identify as well as treat those risk factors. The common risk factors include severe malnutrition, number 2, immunodeficiency, number 3 is recurrent aspiration, which could be associated with GERD, gastroesophageal reflux disease, or it could be associated with anomalies of the upper intestinal tract, like for example, esophageal atresia. In all these conditions, the child can repeatedly vomiting that can predispose to aspiration of feeds. The next condition is a congenital heart defect, associated with increased pulmonary blood flow. So what happens whenever the pulmonary blood flow increases? It causes congestion in the lungs and that predisposes to recurrent pneumonias. And last would be some genetic disorders. Which includes two important disorders. One is cystic fibrosis and the other one is Cartagena syndrome. These are the important risk factors associated with the development of recurrent or persistent pneumonia in children. So please remember, you have to identify these risk factors and correct these risk factors. Only then the future episodes of pneumonia can be prevented. So this completes our discussion of lower respiratory tract infections in children.